We're going to welcome everyone to the Grand Rounds, Ability Grand Rounds for the Center for Excellence in Disabilities at West Virginia University. Many of you have joined us earlier in this series. We're excited for our December presenter, Dr. Andrews. She, see her title, you can see her first slide, People with Disabilities and Medical Rationing During COVID-19 Pandemic. This is a topic just on the side that we've tried to get at here in West Virginia. I'm excited to hear Dr. Andrews' work on this elsewhere. So as a brief introduction, she's a board certified rehabilitation psychologist, an affiliate faculty in the Department of Psychiatry at Dale Medical School at the University of Texas at Austin. Love Austin, by the way. And as she begins her presentation, please remember to mute your line. If you have a question, feel free to raise your hand, put it in the chat. What we're going to do is go through Dr. Andrews' talk, and then at the end, the last 5-10 minutes, we're going to spend that on questions and discussions. But please feel free to put that in the chat. Aside from muting, there's closed captioning. If you need it, go ahead and engage that. That's ready now. And with that, I'll turn it over to you, Dr. Andrews. Thank you for joining us today.
Thank you so much. It's a pleasure to be here, and I appreciate you inviting me. So today I'm going to be talking to you about people with disabilities and medical rationing during the COVID pandemic. One thing I want to add about myself, thank you for that lovely introduction, but I do want to add that I am physically disabled myself. And I just noticed I'm wearing the same shirt as I have on in that picture. I guess I like the shirt. And so I am a triple amputee personally, and although I don't speak for the disability community, of course, I do speak as a member of somebody who has a lived experience of disability. So today I'm going to be talking first about different attitudes and ableism and kind of how that plays out in medical care. And then I'm going to shift to talking about the COVID-19 pandemic and how there were these kind of different waves of issues that affected the disability community with an emphasis on medical rationing. Okay, so I always have to put a disclaimer on my presentation that these views are my own and they're not representing the Department of Veterans Affairs or the University of Texas at Austin. Oops. Okay, so I want to start off by talking about health disparities. Most of us know what health disparities are, but just for the sake of reviewing, these are differences in health outcomes among people at the population level. So this is not about individuals, this is about groups. And these are linked to historical, social, economic, and environmental disadvantages, and they're regarded as avoidable. So these are things that affect health outcomes that are not necessary. They're not have to do with the group, but they have to do with the environment and the situation that the group finds themselves in. And so when we look across a broad range of health indicators and the social determinants of health, we see that people with disabilities fare far worse than people without disabilities. So another term you're probably familiar with is the social determinants of health. And these are, again, different environmental factors that influence the health status, in this case, of people with disabilities, and increase both morbidity and mortality rates. So some of the social determinants of health for disability that we know play a big role in poorer health outcomes are decreased income. People with disabilities are much more likely to live in poverty than those without. Housing and transportation problems, difficulty finding accessible places to live and obtaining accessible transportation, as well as social isolation. So I mentioned already that people with disabilities are more likely to live in poverty, but they're also disproportionately more likely to be unemployed, but yet they incur higher healthcare costs than non-disabled peers. So a higher percentage of their income goes towards healthcare costs. And the other thing that is important to know is that disabled patients are more likely than non-disabled patients to report low satisfaction with healthcare. And there are a couple of kind of systemic reasons for that. One is that the medical system, the medical establishment, is based on the medical model of disability. And oftentimes relies on resources that were not necessarily designed with disabled people in mind. So for example, things that are meant to help people with preventative health, such as a mammogram, are not typically designed to suit the needs of all disabled people. And oftentimes the medical system can be in conflict with the disability community because the way that the medical model thinks about disability versus how people with the lived experience think about disability can be very different. And the way that this typically plays out is that medical providers typically have this inaccurate perception of quality of life of disabled people. So when we ask medical providers how they would rate the quality of life of people with disabilities, they rate it even lower than the average non-disabled person does. And I'm going to talk more specifically about those attitudes here in a few minutes. But we know that providers often harbor these flawed assumptions about disability and that those can get in the way of providing excellent care. So some of the other things that can happen in the medical system is that healthcare providers are less likely to call into question their own assumptions. And those same assumptions are kind of continually reinforced in this medical system that perpetuates the medical model. And what's important is that medical information is only one piece of the disability equation. It's not sufficient to understand or conceptualize what it's like to actually live with a disability, because the disability experience also has social, cultural, political, and historical complexities that the medical model does not account for. So what does this end up looking like in healthcare? We know that there are a lot of stereotypes, biases, and prejudicial attitudes, which we would collectively refer to as ableism in medical settings. And ableism occurs when harmful attitudes are perpetuated towards disabled patients. And harmful is bolded there because it's not always hateful attitudes. They can be other types of attitudes as well, but they all have in common, ableist attitudes do harm. And this contributes towards discriminatory behavior, and then that results then in adverse health outcomes for people with disabilities in the healthcare system. So what do we know about what it's like for people with disabilities in healthcare? And I will say, you know, a lot of the research is based on adults, and we have less data about the experiences of pediatrics and also the parents of children with disabilities in healthcare. But we know that adults with disabilities are more likely to have had a clinical encounter where they felt like the provider didn't listen carefully to them. They didn't explain things in a way that they could understand, didn't show respect for what they had to say, or spend enough time listening to them. And then we have this really recent study that was done by Iazzoni and colleagues up in Massachusetts, and they looked at 714 practicing US physicians nationwide across all specialties. And they found that 82.4% of these physicians reported that people with significant disability have worse quality of life than non-disabled people. So just straight out made that assumption. Only about 40% of these physicians were confident about their ability to provide the same quality of care to patients with disabilities. And just over half strongly agreed that they welcomed patients with disability into their practices, which was, I thought, a kind of an alarming finding. 18.1% strongly agreed that the healthcare system often treats disabled patients unfairly. And this is consistent with the literature, which suggests that providers know that there are problems, but oftentimes they feel stuck and they don't know what to do about it. Now, on the disability side, oftentimes there is a lot of distrust of medical institutions. And this is because the medical institution has a long and dark history concerning disability. So we know that in medicine, disability has been kind of constructed in ways that have been harmful, both as a spectacle, you know, kind of a anomaly, something to be studied, and also as a tragedy, something to be gawked and pitied at. So the disability community as a whole tends to distrust the medical establishment and how it's historically pathologized the understanding of disability. So one of the terms that I'm hearing more and more in the disability community is this idea of the medical industrial complex, which is really highlighting how medical education is so embedded in the history of ableism and other forms of oppression. So I want to talk more specifically about attitudes and ableism, and then we'll shift gears into talking about COVID. So again, I mentioned ableism earlier. It's the same thing as disability stigma. It's prejudicial attitudes and discriminatory behavior towards disabled people. It's analogous to other isms such as racism and sexism. And what we believe is that there's a cumulative effect of these harmful attitudes that can affect people with disabilities. And another thing that's important about ableism is it can often operate subtly and unconsciously. It's not necessarily right out there in your face. So whenever we think about attitudes, we always have to differentiate between explicit and implicit attitudes. Explicit attitudes are those of which we are consciously aware, and we are comfortable expressing those explicit attitudes outwardly, versus implicit attitudes are they're not even necessarily known to the person holding them. They can be subconscious, they tend to be more deeply ingrained and can be more subtle. But it's important to know that implicit negative biases can be reduced, but we have to recognize them and learn how to manage them so that we can control the extent to which they affect our behavior as healthcare providers. So the way that we measure attitudes, implicit attitudes in psychology is through a tool called the implicit association test. And you can take the IAT on many different groups of people. You can take the IAT for race, for sexual orientation, of course, for disability. And when we look at that body of research, we see that attitudes towards disability are among the most negative of any group. And when we look at how people are different on these measures, we see that family members of people with disabilities, they have lower explicit bias. Remember, that's the outwardly shown bias, but they have the same level of implicit bias. Disabled people themselves, when they take the IAT, they have less both explicit and implicit negative bias, but they still show a moderate preference for non-disabled people. And so that would be what we would call internalized ableism. Some other findings are that women tend to feel more favorably towards people with disabilities when compared to men. And here's where it gets really interesting in an academic and medical setting. As our level of education increases, our explicit bias decreases. However, implicit bias actually increases. And so what that tells us is that well-educated healthcare providers are generally not aware of their own biases. And in the literature, we refer to these folks as aversive ableists. They don't want to be prejudiced, but they have this low explicit or outward prejudice, but a high level of implicit prejudice. So this is a really excellent study that came out about 2 years ago in the Journal of Rehabilitation and Psychology, looking at the prejudice styles of healthcare providers. And you can see in the dark blue that a full 60% of the healthcare providers in this study fell into that category of aversive ableists, whereas only about 28% there in the yellow had both low explicit and low implicit bias towards disability. So it's really important to know that even within disability as a category, there are a lot of differences because it is such a heterogeneous group. And so when we think about the different types of disabilities, some are more stigmatized than others. So I created this pyramid to kind of show how physical disabilities, for example, are there at the top. They tend to be the least stigmatizing in general. And then as you go on down the list, you can see that other types of disabilities are more stigmatizing. And when you get to the bottom of the pyramid, you start to see your neurodevelopmental, your intellectual, and your psychiatric disabilities as being the most stigmatized of all disabilities. Now, there's some exceptions to this. So certain physical disabilities that involve, for example, facial abnormalities are very, very stigmatized. Chronic illnesses, in particular, the chronic illness of HIV AIDS is very stigmatized. And then even within each of these categories, there are some differences. So if you think about neurodevelopmental, both ADHD and autism would fall into that category, but ADHD is far less stigmatizing than autism. And the same thing with the psychiatric disability category. Anxiety and schizophrenia are both psychiatric disabilities, but schizophrenia is far more stigmatized. So in general, the most stigmatized disabilities are those that involve mental functioning, are highly visible, and those for which a person is seen as responsible. So in that way, congenital disability ends up being more stigmatizing than acquired disability. And the reason for that is because people assume that congenital disabilities are genetically determined, whether or not they are for real. But they see people with congenital disability as being more fundamentally different, their disabilities as being somehow more permanent. And they are under the impression that congenital disabilities more fully influence the person's traits. And none of that is accurate, but it's all about the assumptions and biases that we have as human beings. Now, this is where blame comes in. We have a need to perceive the world as a fair and just place. In social psychology, we call this the just world belief. And this is where we tend to default to blaming individuals for unfavorable outcomes. So that's why if you've ever heard somebody say, you know, so-and-so had lung cancer, the immediate next question that will be asked is, did he smoke? So disabilities that are perceived as having a mental or behavioral component, such as like a substance use disorder, they're rated as being more controllable than those that are attributed to a, for example, physical cause. And again, even though that's not necessarily accurate, that is how some of this bias and stereotyping works for people with, against people with disabilities. So you might be wondering, what are some of the other relationships that are associated with attitudes towards people with disabilities? Because I mentioned that family members are have about the same level of implicit bias towards disability, even though you might assume that they would be less biased. There are some other groups that fall into that same kind of neutral category. So having a peer or a coworker with a disability doesn't seem to make a big difference in attitudes, and also having minimal contact with the disability community. All of those things don't really have a significant impact on attitudes. Now, if we look at what kinds of relationships are associated with negative attitudes towards people with disabilities, there's two kinds of relationships. One is people who have had negative contact or bad experiences with members of the disability community. Unsurprisingly, they tend to develop negative attitudes. And then the other group is when we do research and we ask, how would you feel about being in a romantic relationship or being a sexual partner with somebody with a disability? That elicits extremely negative attitudes also. So what we do know about what actually affects positive relationships, or what relationships can have positive results on attitudes towards people with disabilities, the key here is power. So when the person with a disability is a supervisor or a boss, or they hold some sort of social or expert power, for example, maybe they're your professor or your teacher, that is actually associated with positive attitudes towards disability. So it's all about power. This slide is from a pretty recent study that does a nice job of kind of pulling together those two concepts that I talked about, the differences between different types of disability stigmas and the way that it's stratified by the type of relationship that is proposed. So in this study, they asked individuals, you know, how would you feel about a relationship with a person with a disability? And there up at the top on that orange line is, okay, I wouldn't avoid this person. I wouldn't necessarily go out of my way to avoid them. And then the purple line is, I would be willing to be friends with a person with this type of disability. The green line is, I would be willing to be neighbors. And the teal line is, I would be okay being coworkers. And then you see kind of a gap, and the red line is family. I would be okay having someone with this disability in my family. And then you see another drop down to that dark blue line, where it says, okay, I would be willing to consider marriage to someone with this type of disability. So you see that the closer the relationship, the lower the acceptance across all disabilities. However, there are big differences within disability. So if you look at HIV/AIDS, that's very stigmatized, and also autism is very stigmatized over here on the right side, as well as mental illness and intellectual disability. Okay, so I mentioned earlier that not all harmful attitudes are hateful. And what I meant by that is we have these extremes. When we study attitudes towards people with disabilities, we see that there are these highly positive and highly negative stereotypes, and they're both problematic. So on the left-hand side of the slide, we have inferior stereotypes. So this is, your typical, we think about disability in a negative way. People with disabilities are dependent, they're incompetent, so on. And then on the right side of the slide, we have the hero end of the continuum. And this is when we really glorify people with disabilities. We kind of describe them as being inspirational or superhuman or heroic in some kind of way. And the idea here is that both extremes can be very harmful. And this is not unique to disability. This can happen in other groups as well. So for example, there are some quote unquote positive stereotypes of Asian Americans, that they're the supposed model minority or they're all really smart, that also have been documented to be very damaging and problematic. So from that side of that last slide, the kind of heroic glorification side, we've seen something come out that the disability community calls inspiration porn. And that's a provocative title. It's meant to be provocative. And these are images of disabled people that have some sort of sentimental or motivational statement. You typically are going to see these as memes on social media. And in the words of the activist Stella Young, she said they have the dual function of making the non-disabled feel better about themselves while simultaneously holding the average disabled person to an impossibly high standard. And there's a couple of examples of inspiration porn on this slide. On the top right, you see an amputee surfer, and it says the only disability in life is a bad attitude. And then on the bottom right, there's a boy playing wheelchair basketball, and it says your excuse is invalid. And I've taken to blanking out their faces and I forgot to do it on this slide, but especially for children, I've taken to blanking out their faces because a lot of times these are pictures that are stolen off of the internet without the permission of the individual who's being portrayed, or if in the case of a minor, without the permission of their parents. So other types of inspiration porn can also be something like the one we see here, really praising non-disabled people for being kind or helping a non-disabled person like you see here, praising people with disabilities for quote unquote overcoming their disabilities, and then calling people with disabilities inspirational for carrying out, daily tasks. I mean, this is a young woman who's going to the prom, and so this is the way that it's portrayed would be considered inspiration porn. Now, I included this picture because a lot of times people are saying, well, does that mean any time that people with disabilities are included in advertisements or the media that it's inspiration porn? And the answer is no, because you can see here, this is a Target ad, and there's a little boy with Down syndrome as part of the ad. And it's not, pointing him out. It's not, glorifying him or shaming him. He's just part of the ad. He's just one of the kids. So this is a good example of inclusion, where people with disabilities are included and represented, but not inspiration porn. And I think the best comeback to all of it is again from the activist Stella Young, and she said, no amount of smiling at a flight of stairs ever turned it into a ramp. And that's the thing with the inspiration porn and these messages, is that you can be the most positive and plucky person with a disability that you can be, and you're still going to run into these systemic barriers that are going to occur. But we tend to over focus on the individual with a disability and discount the role of the environment. So when we think about ableism in general, not just in medical care, there's different kind of levels or types of ableism. There's interpersonal ableism, and that's ableism. I'll explain these more in a minute, but between people. And that's the only type of ableism that is above the surface. So here I have a diagram of a iceberg. And an iceberg, as you know, you can see the top of it, but down below, there's a big, hunk of ice down there. And from a ship's perspective, the part that's under the water is the most dangerous because you cannot see it. So I love this analogy of looking at ableism in this way. So interpersonal ableism might be on the surface. It might be the things that you see or you witness, but there's all this other type of ableism going on that's below the surface that also can be quite dangerous. So I'm going to start with the internalized and intrapersonal ableism. And this is where we distance ourselves as people with disabilities from one another, maybe try to avoid being around other disabled people. And we also try to avoid conforming to non-disabled people's negative stereotypes. So a lot of times people with disabilities are kind of trying to overachieve in this way. And then we also tend to internalize or abide to that hierarchy that I mentioned. So people with physical disabilities may express ableist thoughts and beliefs toward people with intellectual and developmental disabilities based on that hierarchy. And this causes a lot of problems within the disability community because it's been very difficult to bring the community together and advocate for things that would help us collectively because we have this disjointed identity. Now, interpersonal ableism, remember I said that is when it occurs between individuals. So some of the examples of this that you might see would be misplaced sympathy. For example, in medical settings, treating patients with disabilities as incompetent or unable to make their own decisions because of their disabilities, so stripping away autonomy. So other things that we can see that happen in the medical setting that are interpersonal ableism are testimonial injustice. And that's when we discount people's statements or we discredit what they're saying because of our prejudice about their identity, about their disability. Another thing that can play a role here in interpersonal ableism is providers being overly confident. When providers are overconfident, they're less likely to question their first intuitions or entertain alternative hypotheses. They're less likely to consider referring to other specialists or getting a second opinion, and they're less likely to reflect critically about social conditions and determinants of health. So again, over focusing on the individual and not paying enough attention to the environmental and systemic issues. And then finally, we see epistemic erasure. And this is where things that could be very helpful, subjects of possible medical interest, are completely ignored as if they somehow do not apply to that person. So in disability, two topics that oftentimes this happens with are sexuality, sexual functioning, sexual education, reproductive health, as well as parenting. Those are things we tend to not talk about. Then if we go to a deeper level, we have institutional ableism. And this is going to play a really important role as I'm talking about COVID here in a minute. And this is discrimination against people with disabilities within an organization's policies and practices. So an example would be crisis care standards or organ transplant criteria that may be discriminatory. And we also know that there's a lack of education and training on disability for people in healthcare and a lack of services that are adapted for people with disabilities. So then we have structural ableism, and this is where we're emphasizing the role of structures or across institutions. So thinking about, the entire criminal justice system, people with disabilities are disproportionately more likely to be involved, for example. So this is across institutions in laws, policies, and these deeply entrenched norms that cause these disparities in outcomes. So those are just some examples of what ableism can look like at those levels. And then finally, you have systemic ableism, which is entire systems, and these are pervasively and deeply embedded ableist beliefs and ideologies throughout systems. And these are written or unwritten, but they're deeply embedded. And so we might not even recognize them as being ableist until it's pointed out to us. Okay. So I've said this a couple of times already, but in short, we're applying a lot of these individual solutions to systemic problems and putting too much onus on the disabled people individually. So I want to talk next about COVID-19 and kind of how it affected people with disabilities. So we have this first wave. Lund and Ayers have published a couple of really good articles recently, and they've been talking about the COVID-19 pandemic affecting people with disabilities in 3 waves. And so I'm going to use that same language because I think it's really helpful. But in that first wave, we saw this significant issue with healthcare rationing. So if you remember, during the initial global spread, governments and healthcare agencies started to say, hey, I think we're going to have a shortage. First, they were running out of PPE, then they were running out of things like ventilators, and then they started running out of beds in hospitals. And so what happened is a lot of governments and hospitals created these healthcare rationing plans, or as they call them, crisis care standards. And these are meant to outline which patients would and would not be prioritized for care in the event of these shortages. And the issue is that a lot of these plans place people with pre-existing disabilities at an automatic disadvantage, presupposing that the presence of their disability itself meant that they had a lower quality of life and decreased the priority of saving their life. So in the US, we saw these releases of the rationing algorithms, and they were coming out at the state level typically. And it raised serious concerns within the disability community. So a number of different states initially released their plans, which triggered complaints from with the Office for Civil Rights. And the disability community was saying, you're violating federal law, you're violating the ADA because you're discriminating, you're not allowing for reasonable accommodations, and you're basically proposing to deny care based on disability status. And so the OCR responded strongly and said the disability community is correct, and that even with a pandemic, that doesn't mean that disability rights legislation or disability civil rights are suspended. So they found that healthcare rationing plans that discriminated solely on the basis of disability were not legal. So what does this actually look like in terms of crisis standards of care? We know that during an emergency declaration, legal structures can become more flexible. So during COVID-19, and we continue to be under the national pandemic now, Health and Human Services waived a number of federal regulatory requirements. But it's very important, even when there are some things that can be waived, that we make sure that discrimination and civil rights remain. So what happens when the need arises? You have to triage people. The medical resources are scarce, things like ventilators and ICU beds. What we typically see are policies that base these triage decisions on quality of life judgments and exclude patients with specific conditions, aka disabilities. Again, this is illegal. Patients must not be categorically excluded from access to treatment because of their disability. So the idea is that decisions about access to treatment need to consider whether or not someone has a disability. That's not what they need to consider. They need to consider the patient's prospects of benefiting from the treatment. Is this person going to likely benefit from this treatment? But what actually occurs in real life is that if there's not formal guidance, healthcare rationing decisions in times of crisis are made by physicians who hold, as we know, considerable levels of implicit and explicit bias. And so the disability community rightfully remains very concerned that medical judgments will be compromised by underlying ableism and just a general lack of belief in the value of disabled lives. And then these concerns are especially pronounced for certain members of the disability community, for example, disabled people of color who are experiencing intersectional legacies of both ableism and racism in healthcare. So we know that crisis care standards that include people with disabilities in their development are actually less likely to discriminate based on disability, but even though they can be very helpful, people with disabilities have largely not been invited to become involved in writing these crisis care standards. And there's a lot of mystery and kind of shrouded in privacy around these crisis care standards. So I'd really encourage everyone to encourage their institutions to be open and public about your crisis care standards. So what HHS says is that people with disabilities should not be denied care based on stereotypes, assessments of quality of life, or judgments about a person's relative worth based on the presence or absence of disability. So we know that bias is a huge issue. So there's objections to incorporating long-term expectancy, life expectancy, into the allocation of these decisions. So what the disability community is saying is you can't look at long-term life expectancy when you're making decisions about short-term prognosis. And especially because some of these things are so influenced by social circumstances such as poverty and poor access to healthcare. In other words, using long-term life expectancy unfairly disadvantages some people with disabilities and exacerbates other health disparities. Predictions of long-term expectancy are much more uncertain, right? Doctors are much better at predicting short-term survival than long-term life expectancy. And so if we design these crisis care or these triage guidelines properly, we can avoid discrimination and be more fair. So the idea is not to use those categorical exclusions and not to use perceived quality of life. What we can do is use hospital survival and near-term prognosis, but not long-term life expectancy. Another thing that was happening during this stage of COVID was that people who use ventilators in their daily life, so that's how people live, they're on a ventilator all the time, they present to acute care hospitals. There was policies that was saying that their personal ventilators should be reallocated to COVID patients that were non-disabled because of this idea that people without disabilities inherently have a better quality of life. And HHS has come out and been very clear that that is not appropriate to reallocate people's personal ventilators, because what was happening in the disability community is people on vents were afraid to go to the hospital because they were afraid that their ventilators would be taken away. So other things that can be done is to designate triage officers as the decision makers and train them to respect disability rights. So it doesn't all fall on the physicians who are under pressure and having to make these decisions in the moment. And again, the idea is to be able to assess patients individually based on objective medical evidence, not stereotypes or assumptions. And finally, it's important to include disability rights advocates in the development of the policies and their dissemination, because again, we know that it produces better guidance, but it can also demonstrate respect for the disability community and help to avoid paternalism. So I want to tell you a little bit about this case. I'm not sure if anyone has heard of it, but this was the case of a gentleman here in my city in Austin, Texas, by the name of Michael Hickson. And he was a 46-year-old Black man, a husband and father of 5, college graduate, who was working as an auto insurance claims estimator. And he was driving his wife to work about 3 years before the pandemic, and he experienced cardiac arrest, which resulted in anoxic brain injury, blindness, as well as quadriplegia. So what happened was that his wife and his family, they relocated from the Dallas area to Austin to try to get Michael involved in rehabilitation. And they were on a wait list for a rehabilitation program. So he was in a skilled nursing facility where he, like many who were in congregate care settings, contracted COVID-19, and he was admitted to St. David's Hospital here in Austin. So I'm going to play you this recording so you can hear a conversation between Mr. Hickson's wife and the attending physician treating him at the hospital for COVID-19.
So as far as run disability, if it's a certain criteria, and it's not that we're afraid of side effects, it's that you have to fit a certain criteria. Right now, that criteria is requiring an intubation. So if you were to get intubated, then he would be on it. But at this point, with the decision is, do we want to be extremely aggressive with his care, or do we feel like this will be futile? And the big question of futility is one that we always question. And the issue is, will this help him improve his quality of life? Will this help him improve anything? And will it ultimately change the outcome? And the thought is, the answer is no to all of those.
But what would make you say no to all of those?
Because as of right now, his quality of life, he doesn't have much of one.
What do you mean?
So
because he's paralyzed with a brain injury, he doesn't have quality of life.
Correct.
Who gets to make that decision whether somebody's quality of life, if they have a disability,
Well, it's definitely not me.
their quality of life is not good?
So it's not me. I don't make that decision. However, it's will it affect his quality? Will it improve his quality of life? No, the answer is no.
But why wouldn't it? Being able to live isn't improving your quality of life?
There's no improvement with being intubated with a bunch of lines and tubes in your body and being on a ventilator for more than 2 weeks. Each of our people here have COVID and they're in respiratory failure. They've been here for more than 2 weeks.
So they basically are here just letting die.
If I were to be frank, yes.
So if somebody doesn't die, are you going to think that was just
So
chance?
I can count with one hand, which is 3 patients that have made it through.
But you can count 3.
Correct.
Okay.
Correct. Exactly. And I get your point. Like there are 3. However, he doesn't fit those 3. Those 3 are young people that don't have medical problems. This guy is young, but he has a number of medical problems.
So just so you know, my uncle is 90 years old.
Right.
He had COVID.
Right.
He has a bunch of medical problems. He has cancer.
Well, I would consider that a blessing, and every minute that he's still alive, a blessing.
Which is why to me you can't say that though, because
Right.
all the directions pointed to him as being a risk that he would make it, and he did. And I just had another relative of mine pass away that was younger than him.
Well, I'm going to go with the data. I don't go with stories, because stories don't help me. Okay?
Me too.
So did those 3 that made it, did they get that res-dim, whatever it's called?
They did not.
No. They fought it just on their own
Correct.
with oxygen.
With oxygen.
And how long were they here?
Probably about 1.5 to 2 weeks, some of them even longer. So
he's been here now since Tuesday.
right. However, his quality of life is different than theirs. They were walking, talking. People would.
Well, he can't walk, obviously, even walk through the door to get here. So,
Right. And I don't mean to be frank or abrasive or anything, but at this point, we're gonna do what we feel like is best for him, along with the state, and this is what we decided.
so the fact that you're killing someone doesn't
We don't think it's killing,
Okay.
because I don't know when or if he will die, but I do think.
Well, we're all gonna die at some point.
Right, exactly. we all, you're right. We all are gonna die. So I don't know when or if he will die.
Well,
But-
he is gonna die one
But
day.
at this point, I don't think it would be humane or compassionate to put a breathing tube in this man and do the lines and tubes and all that stuff, because I don't think it will benefit him.
And I totally agree with you with the integration part of it. I don't want him to do it, but I also don't think that you should just sit him somewhere to be comfortable until he finally just drifts away.
Right.
That to me is futile too, because that's saying that you're not trying to save somebody's life. You're just watching them go. The ship is sailing. I mean, that doesn't make any sense to me to not try. I don't get that part.
Right. And it's not easy. None of these things are easy. And this is a calculated decision. And we feel like this is what's going to be best for him.
Okay.
Okay?
So if this were your spouse, you would be okay with just
I would
watching.
totally do this if this was my mom, my dad, my brother, my sister, my spouse.
That's a lie. You wouldn't.
You can call me a liar, you can do whatever you want. However, this is how I feel. I've seen this certainly more than you have. And I've seen people die.
You
certainly
still
more
know
have
that
you.
you haven't felt it like this because it's not personal.
You don't know anything about me.
Well, and you don't know about me.
Okay, let's, I
don't
know
know
this is
about me
hard.
either with
I know this is hard, but let's,
This has been 3 years of watching it, so you don't know my life either.
Right, and I'm not saying that I do. But what I'm going to tell you is that this is a decision between the medical community and the state.
And the state. And forget about his wife and his family.
I have nothing to
his
do with
5
that.
kids.
Okay. So
So as far as
sorry, let me move on. So I think, that was a really good example of how it was being conflated about whether or not the treatment was going to help him, but the physician was making determination that his quality of life was not good. He said, other people are walking and talking, and Michael was not. So I think that was a good example. And what was really sad though about that example is there wasn't even shortages at that particular point. I mean, they had a bed for him. There was not shortages. It was just decisions were being made that his quality of life was poor because of his disabilities. And so they decided not to treat him for try to save his life from COVID-19. So following the initial medical rationing, we got into wave 2, and this is where we started to see problems with access to resources and supplies and accommodations. So continue to see PPE shortages as well as COVID testing shortages. So a lot of times the healthcare supplies were being reallocated to hard hit hospitals. So people that needed those supplies for their standard care were having trouble getting them. And so often people with disabilities were struggling also to access routine medical care. Now, many people with disabilities were very concerned about their high risk of adverse outcomes for COVID-19 due to having either primary or secondary health conditions. And so the disability community as a whole was tending to follow more of the stay-at-home guidelines and not seeking face-to-face care. So sometimes people had to make an impossible decision of seeking care and risking contracting and potentially dying of COVID-19 versus not seeking care, but then risking the exacerbation of a serious illness. So telehealth obviously was an option for some people. However, others struggled to access that care due to lack of reliable internet, privacy, or other disability-related considerations that made it difficult to access telehealth. So we know that even though the telehealth rollout was really helpful, accessibility issues were oftentimes an afterthought. The other thing that happened during this wave of the pandemic is there was a lot of isolation that had a significantly detrimental effect on people with disabilities. Finally, wave 3 was issues with vaccine access. So as COVID vaccines became more widely available, it was difficult for people with disabilities to get access. Sometimes caregivers were skeptical about the vaccine. Disability groups were sometimes deprioritized. So there were certain types of disabilities that said, you're high risk, you should get the vaccine. But a lot of other types of disabilities were totally ignored. There was, like with other marginalized groups, some hesitancy about the vaccine for people with pre-existing conditions. And this history of feeling like they have been targets of being medically experimented on in the past. So there was a lot of issues with the history of medical maltreatment and dehumanization, both of people with disabilities as well as people of color. And so there was a lot of misinformation spread about the vaccine, and that resulted in significant hesitancy. Another issue that contributed was things like those vaccine appointment systems, though they were often not screen reader accessible. Again, like I said, certain disabilities were kind of overlooked in terms of the prioritization process. And oftentimes, again, disability groups were not consulted about how can we best roll this out to your community. And so in looking back, researchers have found hundreds of errors related to testing, treatment, and vaccination on states' public health websites, contributing to the sense of confusion and lack of access for the disability community. So I want to end with what can we do, and then we'll leave a couple minutes for questions. So we need to self-examine as healthcare providers and examine our own preconceived notions and biases towards the disability community and people with different types of disabilities. You can take the IAT. Some other suggestions I have are to read works by disabled authors about the lived experience of disability, learn more about the disability rights movement, watch a movie or a documentary about disability and critique the portrayal. More than anything, try not to over-focus on the individual and recognize the role of systemic ableism. So we really need to advocate and not just leave it to families and patients to advocate. So we want to make sure that we're, especially when sometimes families during the COVID pandemic were not able to be as present as they normally would have been. So we have a duty to advocate within our healthcare systems for transparent and fair crisis care guidelines and triage protocols that do not discriminate unfairly against disabled people. Some other things that can be helpful is advocating for bulk provision of medical supplies and full accessibility of testing and services related to COVID-19, ensuring that communications about COVID are fully accessible to the disability community, helping to coordinate support for people that have the most complex needs, and educating other healthcare professionals about the heightened risk that COVID-19 poses to the disability community. So I would encourage you at the institutional level to examine your organization's policies and practices. And today is a great example of providing cultural competence, education, and training on disability to healthcare workers, but there's always more that can be done. We also want to make sure we're identifying ableism across institutions and explicitly challenge it. We want to go beyond minimal access requirements and take steps to be truly inclusive. For example, striving for universal design, which is improving access and usability for a whole broad range of users, not just people with disabilities. So this is just a slide summarizing the things that you can do to be an advocate. And with that, I will go ahead and stop and see if there are any questions that I can answer or comments that people want to share.
Thank you so much, Dr. Andrews. This has been really eye-opening in many different ways. Let me open it up. Someone has a chat. Sonia Singleton. I have a member with Down syndrome that had COVID and had to be intubated with ECMO, and some of the hospital staff stated they felt too much was being asked because she had no quality of life. So very similar situation. Amazing.
Yeah, absolutely. People with Down syndrome, people with all different types of disabilities, but again, especially those highly stigmatized disabilities. It's just very easy for the healthcare system to say, they don't deserve our resources, and just very, very disheartening.
Any other questions or comments?
Question. I know you talked about that hierarchy of stigma. Did you see that in your research when you've seen access to COVID vaccine and supplies during kind of that first and second wave of the pandemic? Did you see that kind of stratify in their access, or did you see a difference when you were kind of looking?
Yeah, that's an interesting question, because I think what we saw with the access to supplies was probably disproportionately affecting people with physical disabilities that needed personal care attendants, that needed daily care, or different supplies or things like that. as well as the vaccine, registering, websites and things like that, that disproportionately really negatively affected blind people who struggled to be able to use those systems to get their vaccine appointments. So it looked a little bit different than the hierarchy, interestingly. And I hadn't thought about it that way till you just brought it up. But I think that was more of a kind of a hodgepodge of different issues that affected various groups within the disability community, but it wasn't quite so obviously, discriminatory in the same way that like we see with, we just don't want to care for this person because we don't think highly enough of their quality of life.
Yeah, the more the less visible disabilities, they were almost able to kind of sneak past and get access. So I really appreciate you bringing up all these points and kind of bring full circle this idea of ableism and how does it infiltrate these ideas of getting access. So I really appreciate the information you shared. Thank you.
Absolutely.
Dr. Andrews, do you have recommendations for families to know what to look out for, and then also what to ask for, and what their rights could be if they feel like they are in a situation like this?
Yeah, that's a really good question. I mean, I think, and that's why I spent, the 5 minutes of like listening to that video, even though it is kind of hard to understand, but it's hard to hear some of the things that doctor was saying. But I felt like there was some real common kind of buzzwords and taglines that he was using, like, well, this is what we think is best for him, that anything that reflects us versus you, that's not a collaborative approach, I think is kind of a red flag. Or any kind of blanket statements about quality of life. I mean, frankly, quality of life is kind of a trigger phrase, if you will, for me in a medical setting, because again, we have all this research that shows that healthcare providers think very poorly of the quality of life of people with disabilities compared to how people with disabilities experience their own lives. So I think that's a concern. I think if I was hearing them talk a lot about quality of life, I would get concerned. I think, always asking for a second opinion is really helpful. I think asking to see policy is helpful, and not being afraid to challenge and say, I'm concerned that these decisions are being unduly influenced by, my family member's disability status. And I'd like to see, your policy on this. And, it's sometimes you just got to be the squeaky wheel. And I know we're all kind of conditioned to, behave ourselves in a medical setting. And I'm not in any way advocating for bad behavior, but sometimes it can be hard to get the confidence to really advocate. But it's super important in these instances that we do find our voice.
Thank you.
Sonia, was there anything related to the story that you've shared with us that you want to say in addition to the chat? I don't want to put you on the spot, but I don't want to.
No, you didn't put me on the spot. I'm sorry. Just that I see this so more commonly today, that our medical system is judging who is qualified for this care, this help. And it's not just people with disabilities, it's anyone that goes into a hospital and needs certain things that maybe they don't have for them, or they don't feel that their insurance will cover. I have another little girl with Down syndrome. She needs a heart transplant, and her local physicians and care team said that they didn't feel that she was qualified for to be on the heart transplant list. So therefore she had to go out of state, and she's in DC trying to get on a heart transplant list because they'd agreed to work with her to get her there. Why does someone have to go out of the state of West Virginia to get the care that they feel that their child or family member needs because someone here doesn't feel that way about their case? Why is it decided by our medical professions?
Right.
It's disheartening.
It's very disheartening. And And I hope that if folks took anything from this presentation today, it's that, healthcare providers are humans. And as humans, we have these biases, and healthcare providers, because of, and I'm a healthcare provider, I'm part of this group, but it's like, because of the way that we were educated and trained in the medical model, we're even more biased towards disability. So we're really not the people that should be making these decisions. And these decisions should not be based on assumptions and stereotypes. They should be based on objective information. And you're right, transplant is another area that is a huge problem. I actually do a lot of pre-surgical psychological evaluations, and I always feel really glad I'm in that role, because there may be somebody with schizophrenia that needs a heart transplant, and it's very easy for another provider just to say, oh well, he's schizophrenic, he's not going to be able to comply or do all the things that are needed, or just to have the outright attitude of his life isn't worth as much as the person next on the list. So it's really important that we advocate and spread the word that we need to have fair and objective processes and not rely on flawed human judgment and biases.
I just wanted to interject one more time, and I'm sorry if I'm taking up your time, but I work in the West Virginia IDD waiver program. I own my own case management agency, and I see parents who are afraid to speak up, who don't want to rock the boat. They do this interagency, and they do this with doctors and just all kinds of specialists, because they feel that they are not educated enough to speak up, even if it's on their child's behalf and they know better for that child. I mean, I think we need to have a lot more teaching of being able to advocate for our family members, because parents are scared. They've had these, IEPs where their child needs this, but the school system says, no, we're not giving it to you. And they don't get it. So they're not used to getting what they need for their family members. And sometimes they've gotten a lot of flack from it, or, recourse from it. So they're very drawn back, or they feel that they don't know enough. So we definitely need a lot more people in there to help advocate and educate our families, because they're afraid to speak up.
I agree.
Real quick, I know we're over the hour, or Dr. Andrews, I'll just follow up with you on that. There's, on the research side, there's NIH has an N3C database that looks at COVID specifically. Not all, as you know, medical centers contribute, but it is a pretty big sample. And a group of us developed a domain focused on disability, individuals with disability, with this question in mind, particularly during COVID. When we got into it, it has been considerably difficult to try to find the variables that are in the electronic medical record that would represent this bias that you talked about today. And I'll follow up with you, because I'd love to get your thoughts on it. I'd love to get you on those domain team meetings if you have time, but it's trying to tease out and find, there are differences, but you don't know if it's related to the bias or the condition, or both, so that's what we're hoping to do.
That's great. Yeah, it can be really tricky.
Well, thank you again. I mean, this was a great presentation. You do very important work. Thank you for doing that. And we hope to have you back soon, but thank you for spending this time with us.
Thanks for having me. I hope everybody has a great day. Bye-bye.
You too. Bye-bye.